Welcome to the Ticktective podcast, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your host, Dana Parrish, and I'm the co-author of the book Chronic, and I sit on the advisory board of Bay Area Lyme Foundation. This program offers insightful interviews with scientists, clinicians, patients, and other interesting people. We're a nonprofit based in Silicon Valley, and thanks to a generous grant that covers 100% of our overhead, all of your donations go directly to our research and prevention programs. For more information about Lyme disease, please visit us at bayarealyme.org. I am here today with the wonderful psychiatrist, Dr. Robert C. Bransfield, MD, DLFAPA. He is a graduate of Rutgers College and George Washington University School of Medicine. He completed his psychiatric residency training at Shepherd and Enoch Pratt Hospital. He's board certified by the American Board of Psychiatry and Neurology in Psychiatry, and is a distinguished life fellow of the American Psychiatric Association. He's a clinical associate professor of psychiatry at Rutgers Robert Wood Johnson Medical School and the Hackensack Meridian School of Medicine, and he is well published in the peer-reviewed literature. Welcome, Dr. Bransfield. Thank you so much for talking to me today. How are you?
Thank you, Dana, and thank you for inviting me.
It's my pleasure. You know, I've learned so much from you over the years about microbes and mental illness. You've blown my mind a million times, and I cannot wait to share your knowledge today with everybody who's going to watch and listen to this podcast. So my first question is, does psychiatry pay enough attention, and does medicine pay enough attention to microbes in infections, pathogens, in mental illness?
Well, not enough. And if you look at old views of what caused psychiatry, it used to be demon possession, and then we blamed our mothers, and then we blamed serotonin, and it doesn't quite make sense that there's something that causes psychiatric illness. They don't just come out of nowheres. The problem is that nothing in the known universe for its size is more complex than the human brain. So understanding the pathophysiology of the human brain is very challenging, especially the part that involves psychiatric illness. And that's much more complicated than general neurological illness, where the circuits are not as complex as the circuits that impact psychiatric functioning. So it's something causes a problem. And when we look at all the possibilities, there are many contributors that contribute to mental illness. And microbes are just one of them, but I think it's a very significant one. When you look at it, and when you look long enough and hard enough, it does explain many illnesses, psychiatric illnesses. And it's not just a microbe, but people have to have a genetic vulnerability. There aren't really mental illness genes, but they're genetic vulnerabilities that environmental circumstances trigger. And infections are one of these many contributors, which seems to be very significant when we look at it long enough and hard enough. And now that we have better brain imaging, neurochemistry, and gene expression, upregulation, downregulation, awareness, the more we look at that, the more we're seeing that infections play a role, and are mediated by an immune process. There's infection, an immune process, and then that causes the circuit changes and the mental illnesses. So it all makes sense. But I think a lot of people that were trained in medical school decades ago were trained that the brain is a mysterious black box, and psychiatric illness just comes out of nowheres, and there's no explanation for it. And now we know there is. But it's very complicated, but it can be explained.
So is it that some of these microbes are actually in the brain, along with the different immune factors that are going on?
Well, I think there's three basic things. One is there may be infection in the brain itself, and another is it can be infection in the body. Mm-hmm. And being in the body, it has an immune effect and a metabolic effect, which in turn impacts the functioning of the brain. so that immune activity in the body has an immune effect in the brain. and that alters brain functioning. That's the second way. And the third way is where there's infection in the vasculature that then affects circulation, which in turn impacts mental, psychiatric, neurological functioning. So those are the three mechanisms. And people better understand infection in the brain. And a lot of times they make the mistake that you have to have signs of infection in the brain in order for an infection to impact brain functioning, when more often it seems like infection in the body can do it. And the other thing that adds to it is it may be a prior infection that's had a impact, a dysfunction that then persists long after the infection's gone.
I see. So is there a way to find out whether your neuropsychiatric symptoms, your psychiatric symptoms are caused by an active infection versus something else?
Well, you look at all the contributors to disease and all the deterrents to disease, and you have to add them up. And one thing is what triggers it in the first place, what causes it to perpetuate, and what causes it to progress. So a very significant thing is doing a very thorough history, a very thorough assessment, looking at how the history evolved and looking at all the symptoms. Now, when you have these infections, they invariably are multi-system. They impact the entire body.
Yeah.
And so you have to look at that. You can't use what we call silo mentality, where you just look at a narrow area. And an example of that is when we look at schizophrenia and bipolar illness, those people don't just have a mental illness. They invariably have a cardiovascular component and a metabolic component to their illness.
Yeah.
So they have something that affects them. And as psychiatrists, we pay more attention to the psych part, but that other part there is there. For instance, schizophrenic patients may die 19 years sooner than the average person,
Wow.
and bipolar patients 13 years sooner. Not necessarily from suicide, but often from these general medical problems. So you have something causing that immune reaction, causing dysfunction that's multi-system. And a lot of these things fall in that category. So you have to do an old-fashioned medical student workup that, unfortunately, with our algorithm-driven, computerized way of charting, it's hard. It's becoming a lost art to do an adequate history and an adequate multi-system review of systems exam in a way that really reveals truly what's going on.
Yeah. I don't hear about psychiatrists even evaluating for infections or considering infections. And that's one of the reasons why I really wanted to talk to you today, because I think that the amount of education that you've given to doctors and sort of change their minds about this has been reverberating throughout their patient practices. Because, you know, I hear from everything. I hear from people that did get the diagnosis right, but more who their doctors missed it and they suffered for a really, really long time. And I'm wondering, what are the most common infections that you see that are causing psychiatric manifestations, and what are the most common manifestations of these diseases?
Okay, well, actually, it is in the American Psychiatric Association guidelines for the assessment of adults to consider Lyme disease. That is there. Yes,
that's great to know, but they don't. But why don't they do it? I hear it.
No, I think some do it. I think we do symposiums, and I think gradually, once you start seeing it, then you can't stop seeing it. It's like the Yogi Bear quote: "I never would have believed it if I didn't see it." And once you see it, then you think, "Oh my God, I've been missing this all the time." And so there's and psychiatrists are trained in general medicine first, and then in psychiatry. So we're physicians first and specialists seconds. And we go back to, let's say, syphilis, where syphilis was clearly a good example of a psychiatric, of an infection causing psychiatric illness. And many of the state hospitals were filled with syphilis patients. Then once that was treated with penicillin, people thought, kind of drifted away from that. But there's been awareness of many different infections. Now, the infections are usually the 3 V's, okay? So the 3 V's are vector-borne, venereal, and viral. And invariably, you're looking at these low-grade infections that can linger. Now, some are hit-and-run infections that may do their damage and leave. Some may be chronic, but they may be hard to detect. And some may be relapsing and remitting. Think of, let's say, shingles, for example, that when you're more immunocompromised, it may then be reactivated. So they may fall into those categories. But I think we have to pay more attention to. See, if we pay attention, we know how to treat symptoms in psychiatry, and we have drugs that treat symptoms that we never had before, and that's wonderful. But treating symptoms is only part of it. We have to look at what caused it in the first place. Is that still causing it? Contributory. So we may have to address infection. We may have to then address the immune reaction, because the symptoms are invariably immune mediated and metabolic mediated, and then the symptoms. So there's a vicious cycle of how these 3 components interact, but also we need to educate so that there's awareness of how they interact.
Yeah.
And we can break that cycle in more than one way. So that gives us more options for treatment and more options for prevention.
There's so many layers to this, and it's so hard to unravel sometimes when you're the patient. Where do I go first? What do I do? Will my doctors work together? I mean, these are just such complex diseases.
Yeah.
And
well, like when I do an assessment, I one of the journal articles I did, I took 100 patients that were clearly CDC positive that no one could say, well, that wasn't Lyme.
You're talking about for Lyme, right?
Yes, for Lyme.
Uh-huh.
And then I did my complete assessment, which is like 270-some questions. And the average patient with Lyme had 82 of those symptoms.
Wow.
Now, the average medical student that was one of the controls, I had 4 controls, had 4 symptoms. The average patient who was a Lyme patient, in looking at their history retrospectively, had 4 symptoms.
Wow.
So they went from 4 to 82 symptoms. So when you have that many symptoms, how do those symptoms interact that contribute to disease progression? So you have to kind of, in figuring out a treatment plan, look at that and look at where do you start? Are you going to give 82 drugs? No. You have to look at what's driving it, be it infection or symptom or immune functioning, and intervene in a way that's most effective. And then you work your way down the list.
So what are the most common psychiatric manifestations of Lyme or other vector-borne diseases that you see?
All right, well, first, break it down in different areas. For instance, cognitive,
okay,
emotional, behavioral, neurological, and general medical. The cognitive, that you can break down into 4 areas: attention, memory, processing, and executive functioning. Now, attention, it looks somewhat like an acquired attention deficit disorder, but one difference is there's more of a sensory flooding, a sensory overload. And that's what makes it different from attention deficit disorder. That patients with Lyme often, like, I'll use the example of Times Square, just too much. I can't take it. Okay. And it's not just distractibility, it's an inability to filter it out. So it's flooding, and then that can make them aggravated. So often that contributes to reclusiveness. But they also have low frustration tolerance, they're distracted, a lot of the symptoms that we classically think of with ADD. And then memory, you particularly see working memory, short-term memory first compromised. Long-term memory is usually preserved better, although often long-term memory is better before the onset of the disease. And it's hard to develop new information and retain it. Depends on the severity of disease. And in processing, you often see slow processing or impairments of processing. And processing is digesting what comes in and organizing what goes out. So digesting what comes in is an example of a Peanuts cartoon where the adults are talking and it's wah, 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 wah. So you hear people talking, but you're not, boom, digesting it fast enough to be a part of the conversation and be able to give an answer So there's this slowness. It's like the old computers that were slow to download the website. And for expressive, you can see where someone struggles, where they, what do you call it, trying to think of what's the name of,
Yeah.
and there may be errors in processing, saying the wrong word, neologisms. And then with executive functioning, that's the ability to create and sustain goal-directed behavior. And there can be a lot of trouble, a lot of problems with time management.
Yeah.
Trouble, time escapes a lot of patients, and organizing, planning, prioritizing, difficulties with that they never had before. Although innate intelligence can remain intact, but there can be difficulty with organizational skills. So that's the cognitive. And then the psychiatric, you can see just about any psychiatric illness in a DSM-5 that you can see a lot of times depression, anxiety, different kinds of anxiety. You can see mood swings, particularly, you see that more particularly when someone's infected younger. I think the age at which you're infected and has a bearing on how it manifests.
Oh,
And,
interesting.
yeah, and then like behavioral symptoms, like one symptom unique is the intrusive symptoms that, and we think of that often with post-traumatic stress or OCD, where it's a thought, an image that's not something you would voluntarily want to think, it would just come to your head and it would be frightening. And then it could be horrific images, it could be urges to do things that are inappropriate or destructive or aggressive. And it's like, where did that come from? It often goes with temporal lobe activation.
Yeah.
And you can see suicidality, sometimes homicidality, although that's, not common. But when you have a large number of people impacted, like a Chinese study showed that 14.5% of the population has been exposed to Lyme disease.
Yeah.
And so this is pervasive, and that's throughout the world. So this is very pervasive, and we have to consider it, I think, constantly in psychiatry and in general medicine. It's a contributor, but maybe not the sole contributor, and it may be add other contributors to illness.
Absolutely. Now we have the pandemic of COVID-19, and we know that impacts the brain, and it is also a neurologic infection, and it goes all over the body. What are you witnessing? And is there overlap between Lyme and vector-borne diseases?
Well, you often find when there's a new emerging disease, there's great difficulty handling it effectively.
Mm.
And there's some people that say, well, you have to give me research money so that I can do a controlled study, and we can't do anything until that happens. What you really have to look at a lot, which there's a failure, is looking at frontline physicians who deal with this.
Yeah.
And when you're dealing with a patient and they're in distress, you have to decide, what am I going to do today to help this person today? I can't wait until some of these studies are completed. And we can always study more and more, but there's a limit that you can overstudy, and then it's an ethical issue when you overstudy something where you have a fair amount of knowledge already. So you often have this then a power play of who's in control of this new emerging disease. And
Yeah.
there may be people that are interested, see it as an economic opportunity with different test kits or getting approvals. And then there's other like frontline people that say, well, let's work with what we have and make the best of it. But that doesn't really have economic potential for any large entities, but it does help patients. So there's often that battle. We saw it with AIDS, we saw it with chronic fatigue, we saw it with Lyme, we saw it with COVID. And then if, let's say, you can recognize that these treatments really do work, then it's hard to get the fast track approval of these other of these drugs that have economic potential. So there's often this battle, and the finances and special interest interfere with what might be best for the patients.
Absolutely. I don't think it's at all a surprise that we're seeing some of the same playbook playing out that we experienced with Lyme, chronic Lyme, now with chronic COVID. There was an article that came out recently in the New Republic called Head Case. We might have long COVID all wrong, by somebody named Natalie Shore. And basically, this article claims that a lot of the psychiatric manifestations and manifestations of long COVID, chronic COVID, whatever you want to call it, are functional neurologic disorders. They call it FND. What does that mean? And is that a legitimate diagnosis?
Well, that means it's a cop-out and it's not legitimate, but it's what people do. And when you think of it, like, you have to look at the mind-body connection. And there's psychosomatic illness, somatopsychic illness, multi-system illness that affects both, and medical uncertainty. And you have to label those four things appropriately. Now, a lot of times where there's medical uncertainty, there's a tendency to say, well, what's functional or psychosomatic. Now, you have to understand what exactly is psychosomatic medicine. Now, psychosomatic illnesses don't suddenly begin in midlife. That doesn't happen. There are lifelong tendencies. For instance, someone may have a vulnerability that stress goes to their stomach or their bowel, or they sweat, or they have palpitations. That's there from childhood, and it doesn't suddenly begin in the middle of life after an infection.
Right.
It's always there. It may come and go with times of stress, and for some reason that they may have a vulnerable organ, and when that person has stress, it becomes symptomatic in that organ, and that's really. But when you have there is really no such thing as multi-system psychosomatic illness. That
right.
It's that would suddenly be acquired abruptly.
Yeah.
That doesn't occur. It just doesn't fit with the diagnosis. So a lot of times it's the cop out of you don't know the diagnosis, but you're trying to dismiss it. Now, a lot of times people want rigidity of diagnosis, because rigidity of diagnosis makes it easier to use criteria for getting drugs, vaccine, or test kits approved.
Right.
And they often make it more rigid than it really is, so that you have that economic potential fulfilled. And and a lot of people really don't know. I don't know what the background of that person is. Is that someone who's trained in psychosomatic medicine? Is that person a psychiatrist who's also an internist? They have the skill set to really look at that. And when you look at
it seemed like it was an agenda-driven piece. It was what I would call a hit piece. We've seen it a million times in chronic Lyme, and that was the perception of the long COVID community as well. And, we now have 300 studies approximately that demonstrate persistence of the virus, COVID-19. So to call it functional, I think people don't understand how harmful that is to patients.
Well, it's beneficial maybe to the insurance industry, or
right.
Say this is functional and it's not a disability. There's brain imaging article that shows there's changes physiologically.
Yeah.
And if you measure it properly, you can see that there's changes after the infection that weren't there before.
Yeah.
So there is a defined physiology when you look hard enough, and when you do an adequate history and assessment. If you do a sloppy assessment or a biased assessment, then you can come up with those things. I've had different reporters contact me, and I can tell sometimes they have an agenda, so where they want to promote something, and when I say something negative, it never gets included, or
right,
they may include nothing that I say.
Right.
And they may twist the words, because, like, why are they doing that article? Like, who's paying them?
Right.
And when you dig at that enough, there's often someone who's paying that person
yes
to do the article, and they're trying to promote some agenda, and that's not always clear, not always disclosed when that article hits the media.
Absolutely true. Absolutely. So in terms of the psychiatric manifestations of microbes, one of the things that you've talked about before is autism. And I'm
Mhm.
curious about the relationship between pathogens and autism and how you discovered that that was
Well,
possibly happening.
okay. I treat, I specialize in treating treatment-resistant psychiatric illness.
Mhm.
So they were people that failed on everything, and then they would be referred to me to try to figure out what else can we do. And in working with those people, some of them had some infectious component to it. Not all of them, but some. And then once that was addressed, then treatment was more successful. And as a result of doing that, I years ago was getting a lot of AIDS patients, and then chronic fatigue patients, and then Lyme patients. And it's psychiatry, when an illness is lost and mismanaged in general medicine, these patients are invariably referred to psychiatrists,
Yeah.
because it's like, I can't figure it out. It must be all in your head. So find thee to a psychiatrist.
Yeah.
And then, so I would see these patients, and I would see a lot of Lyme patients repeatedly. And I would have, like, some of my female patients that would say in passing, oh, I happen to have an autistic child also. And I thought, gee, that's interesting. You've got double trouble here. You've got Lyme and you have an autistic child. And then another one would say it, another one would say it, another one would say it. I
Yeah.
say, wait a minute, this is too much of a coincidence.
Yeah.
So then I looked at it further. I've done, I think, about 8 different articles on Lyme and autism, the association. And I looked at it further, and there's 22 different infections associated with autism. And there's also probably other causes that are contributors to autism.
Sure.
But autism can be 2 types. You can have it passed on congenital, but you can also have regressive autism. And that's where a child is not born autistic. They're developing normally, and then at a certain point, like 1, 2 in that age range often, then they suddenly crash.
Yeah.
And they decline, and they show autistic symptoms there.
Yeah.
And those patients are usually the easier ones to treat, because it's
So what's the
less
difference in
recurrence.
terms, are you saying those are not congenitally infected kids? Okay.
Right.
So they acquired it out in the world.
Yeah, they acquired it early, and now sometimes it's difficult to test, because the immune system may not see it as foreign, and you really have to know the testing is not reliable. That's the problem. I did one article where I looked at 3 generations of Lyme with autism, and now there's a 4th in that family. The grandmother had it in their heart. At autopsy, they had Lyme and other tick-borne infections. Then the mother had autistic traits, 4 children with autism, and then one of those children then went on to have 2 autistic children.
Wow.
So,
Wow.
and we have brain imaging showing the deficits. We have the blood work, and so it comes up a lot. And some of these patients, where you recognize it and you treat it, you see surprising improvement.
Yeah.
And it's autism a case of autism can cost society several $1 million in their lifetime management. And if you can treat that and prevent it, that's a wonderful thing to do. Not just the cost, but the emotional distress and the impact to the family and the patient themselves. So I think that's significant. You know, we have to look at some of these things that are baffling, and why is there more and more autism than there used to be?
I was just going to ask you that.
It is increasing, and when you let's say look at these infections, it can be a mix, and when you have this mixed infection and there's an interactive effect, it's hard to say. Think of AIDS as an interactive infection.
Mm-hmm.
So it's like 1 + 1 doesn't equal 2. 1 + 1 = 11.
Right.
But it's not just 1 + 1. There may be multiple things, and there may be multiple infections that we haven't yet identified. We're finding that with every year we're finding new tick-borne diseases or new strains, and it's a lot more complicated. And we have to have the humility and not have the arrogance that has been there previously with tick-borne diseases and these infections. We have to be open to it and have to understand it, but it takes a multidisciplinary approach if people don't usually work together and speak different languages.
Absolutely. So when you have patients where you're treating with somebody who might be also treating your patient for an underlying vector-borne disease or chronic COVID kind of issues, if you're treating with psych medications, as that person's health improves under treatment for the underlying cause, are they able to get off of psychiatric meds sometimes? And, how common is that?
Yes, I've seen that. Sometimes, not always. It depends on how entrenched the illness is. And if it's been there for a long time, you can see disease progression that sometimes you can't always reverse by treating infection that started in the first place.
Yeah.
You can't always stop an avalanche at the bottom of the hill. So it's, but sometimes you can.
Yeah.
So, and a lot of times when you treat the psych meds, the person's less stressed. And if they're less stressed, and particularly if you treat the sleep disorders, those two things help their immunocompetence to improve. And then they're better able to fend off whatever infections might be there that's still causing progression. Sometimes the infection causing disease progression may be different than what originally started it.
Interesting. One of the things that we quoted you on in our book, Chronic, Dr. Phillips and me, was about sleep. And you really talked a lot about how important, people peripherally sort of know that, but not as deeply as you do. And one of the things that I thought was so interesting is that you said pretty much all of your Lyme patients have some kind of sleep disturbance. And what's that about? And what kind of disturbances? Is it all insomnia? Is it trouble waking up? Are people just chronically fatigued? What's the problem?
Well, a lot of it's non-restorative sleep. There was a prior study by Greenberg that showed 100% of Lyme patients had sleep disorders of one sort or another. So non-restorative sleep is a big thing, because that, if you're not getting delta sleep, that's where your body regenerates and helps with the immunocompetence, with early inflammation, later adaptive immunity. And then that contributes to growth hormone, that's a master hormone, and so you get hormonal disruption, and then you get the terrible triad of non-restorative sleep, fatigue, and cognitive impairments, brain fog, etc. So that's frequently where I intervene first. Now, then I have to say, well, what is the sleep disorder? So if it's non-restorative sleep, then I think what would promote deep sleep that's more restorative? We call it delta sleep. And do they have trouble falling asleep, trouble staying asleep, early morning awakening?
Yeah.
And there's different explanations. Trouble falling asleep, is there something, thoughts? Is it emotion? Is it physical discomfort, a physical symptom? And then waking up in the middle of the night, a lot of times are various physical things, sleep apnea, reflux, urination, palpitations, etc. Early morning awakening is often depression. So then you address those things that interfere with the sleep. So like, why are they having trouble falling asleep? Are they having intrusive symptoms, obsessiveness? Is it generalized anxiety, hyperarousal? Is it post-traumatic stress? You want to address whatever it is that contributes to that, and work your way down the list of what helps a person to, recover better.
What do you use? What are, some of the drugs that you use for people who are having trouble falling asleep?
Yeah. All right. One thing to add too, there's also other oddball sleep study, like narcolepsy. You see that, you see the sleep app, you see behavior disorders, you see sleep paralysis, hypnagogic hallucinations.
Interesting.
Those things, all those things. I might start with something like trazodone that promotes deep sleep.
Yeah.
And it's and there's a lot of your approved sleep aids don't promote deep sleep. There's only the Xyrem and Xywav promote deep sleep, and those are approved for narcolepsy or idiopathic hypersomnia. And So it's difficult of getting those approved for any off-label use. That's impossible. So a lot of times you're using things that are just meds that we know by research help with that deep sleep. Now, sometimes the traditional sleep aids can help. It depends on what's the problem with the sleep and addressing it. And then a part of it is a sleep disorder isn't just trouble sleeping, it's a circadian rhythm disorder.
Yeah.
So part of it is being able to be awake during the day. So sometimes you might do something that's wakefulness promoting during the day, like wakefulness promoting agents, where you normalize the sleep cycle. So normally you go to sleep, you get deep restorative sleep, and then you jump out of bed ready to attack the world. You get a slump at 4 p.m, and that normally occurs. It's part of our biorhythm. If you're in Europe, you take a siesta. If you're in England, you have tea and crumpets. If you're here, you have Starbucks and you just drive through it.
Uh-huh.
And it's, but that's part of our, and if you had a lack of sleep the night before, then you might have more trouble then. And also the people that, let's say, have the sensory flooding, they often have a reversal sleep cycle because the daytime stimulation's too much. So they become night owls. So
I see that a lot with kids too, with PANs and PANDAS. Do you think that's is it like more common in kids? I hear from parents all the time, like their kids are sleeping during the day and they're up the entire night.
Well, it's easier for kids because they don't have to be in the office at 9 o'clock to work.
Yeah.
And the pandemic promoted a lot of bad habits in people and social isolation.
Yeah.
I hated the phrase social distancing. It should have been physical distancing. Okay? And it's because we need social connectedness during a crisis, not distancing. But children, they can do that. And I think they then stay up, with their cell phones, or text messages, computer games, those kind of things. And the light exposure with that maybe is an added thing that could be contributory.
So one of the things that I found really interesting in conducting so many interviews with patients for our book was the amount of times people with Lyme and other infections were thrown into psych wards. Some of them went on to become physicians, and many of them, all of them, did not get a proper diagnosis or treatment until after they were released. And somehow a parent or somebody stumbled upon some literature that said that different infections could have caused their symptoms. So how commonly do you think psych wards, prisons are filled with people that have undertreated brain infections or untreated, unrecognized?
Well, they did a study in the Czech Republic, and they showed that a significant percent of those people tested positive for Lyme compared to the general population in the same area. So, and it was a spectrum of different conditions. It wasn't just bipolar, it wasn't just schizophrenia. It was a whole spectrum, but that's what you see. It depends on what the genetic susceptibility of any given person is, what symptoms they may manifest. Now, you can't say they don't have psych symptoms, but it's not mimicking. You just understand the etiology of the psych symptom.
Right.
And so then they may do the symptom. They may treat the symptoms, but they're not addressing the initial etiology of the symptoms or the illness. And it's very prevalent. Now, I'm in New Jersey. New Jersey was #1 for the number of Lyme cases in 2017. When the study was repeated in 21, it was #1 again.
That was where I got infected in New Jersey.
And it's so there's areas, but you also, a lot of areas where they say aren't so prevalent probably are. They may be some other Borrelia. They aren't necessarily Borrelia burgdorferi B31 strain from Shelter Island, a laboratory strain that's used as the reference point. It's or it may be Babesia, Bartonella, or some other infection that's contributory, or something that's unknown that we still have to figure out.
We should talk about the testing because you just mentioned it. And I think that most people do not know how poor the Lyme testing is, how inaccurate most of the Lyme testing is. Can you talk a little bit about how a doctor that's new to the subject should be understanding this?
Well, if I get a patient that says they might have AIDS, then I can do a test and it's pretty reliable. Now, if I then get a patient say, well, they might have Lyme, I could do a test, but that the AIDS test is 500 times more reliable than the Lyme test.
Yeah.
And AIDS, the Lyme test was never standardized for late stage disease. And it's a positive test doesn't mean you have it, and a negative test doesn't mean you don't have it. There are a huge number of variables. It could be a different strain of Borrelia that it wasn't standardized by. And Lyme causes immunosuppression. And how can you use an immune-based test with an infection that causes immunosuppression?
Right.
And the Dearborn criteria is askew, and a lot of people confuse the surveillance criteria with diagnostic criteria, even though the CDC has a disclaimer saying otherwise. So if you look at, let's say, the usual way it's tested, and there aren't adequate warnings with the commonly used lab test, that a surveillance criteria, it picks up 30, 40,000 cases a year. Yet the CDC with their own study showed that there was at least 476,000 cases a year.
Yeah.
So it picks up less than 10%. And look, there's one study showed 3.4 million Lyme tests are done per year. So that means it's 101 ratio. For every 100 times a doctor says, gee, this could be a Lyme case, he sees a positive test once. And I think a lot make the mistake, well, I'll do a Lyme test, and if it's positive, you have it. If it's negative, you don't. And that's not how you assess Lyme disease.
Right.
You have to do the total clinical assessment. You can't be lazy and just do a test that's poorly standardized. The two-tier test has a 50% reliability, and particularly it was never standardized for late-stage disease. So there are many, many variabilities that make the test worthless. But yet, if you were to really make it clear this test is very flawed, then a whole body of research is wiped away, which should be wiped away because it was based on a flawed foundation for diagnosis.
Yeah, absolutely.
So you have to look at how you define it, and when you look in general medicine, if you have a chest pain, and if I said, well, I'll do a EKG, and if it's negative, you're not having a heart attack, but maybe your enzymes are elevated. Maybe your enzymes aren't. No, you have to look at the total clinical assessment.
Correct.
You can't look at one test alone. Where in medicine do we do that where it's valid? Okay. You have to look at everything, and especially when the testing is of questionable value. You have to do a total clinical assessment. And a lot of people are invested more in the testing and get patents from the test. And there's a bias towards giving inordinate weight to testing that's flawed. And I think that's a big part of the problem. And I think a lot of infectious disease, they're used to having tests that are more reliable. So they do the test, and that says what it is or what it isn't, and then you go from there. But you can't think that way with Lyme disease, with these tick-borne disease. You have to think differently, and people have trouble adjusting to that. And how many infectious disease doctors do a proper cognitive and psychiatric assessment that you have to consider in making a diagnosis? Zero. Or I guess some do, some might, but it's and do they have the time for it with the way our healthcare system is, that with certain economic systems, you have to see a patient every 8 minutes or something like that. So a lot of times you do the test, you don't have time to do a clinical assessment. So part is the failure of how our system's designed prevents us from doing something that really requires a lot of thought. And
isn't it so much dogma? Isn't it? Like you're making me remember something really. I don't think I've ever even mentioned this because it didn't feel relevant until now, but I think it's important. So yes, doctors are really pressed for time. I was so sick after I got Lyme, and I was treated for 3 weeks with Doxy. I had a bite and a bullseye. I was treated within a few days of my bite. So again, there's this dogma about if you're treated really quickly, you don't go on to have chronic infections. That's completely untrue in many, many cases like mine. I went to 3 ID doctors, and one of them, although he was part of NYU, was also a concierge might be too fancy of a word, but I paid out of pocket significant amount of money to see him because he was supposed to be so great. So I asked him, do you think this could still be a result? I had tons of symptoms, rashes, trouble breathing, all kinds of new joint pain, visual problems, every single thing in the book. Do you think that this could be still from that tick bite? I knew nothing at the time. Okay. I knew nothing. And he said, no. Why not? Because I went to medical school, was his answer. And then I pressed him further. But there has to be some reason why you're saying that I was totally healthy before my tick bite, and now I'm falling apart at the prime of my life. He said, well, Lyme is killed 100% of the time in the test tube with doxycycline. You took 3 weeks of it. You're cured. He wouldn't evaluate me for any other vector-borne, tick-borne diseases, which I did end up having Bartonella as well. And I did ultimately go into heart failure because all of these doctors literally just told me without any exploration, it wasn't Lyme and that was it, and they knew it. And that I've never been treated that way before. What is that about?
Well, you can't say what it's not unless you know what it is.
Okay, good.
And he did not give an alternative diagnosis.
Is that your dog?
Treatment. Yeah, this is Loki.
Hey, buddy.
He's annoyed that he's being left out. So
I totally understand. My dog is sleeping in the other room. I'm amazed she hasn't come in and barked at me for food, but I'm glad. No, it's okay. I love, we love dogs here. So.
Yeah, and dogs are interested in Lyme disease because they can be victims of it too. And
absolutely.
They're sentinels of Lyme disease. Okay.
Yeah.
So what happened there, there's these studies, and when you look at it carefully, a lot of times they're flawed. Like there's this one crazy study that you take 1 or 2 doses of doxycycline after tick bite. That's outrageous.
It's ridiculous.
And I see the cases, I see the failures of that. If those things work, my average person is usually 10 years post-infection, and they get these problems. And they never, with those studies, looked later. They never looked 10 years later to see, did that really prevent disease development? And then when they look at the psych symptoms, well, they say this is subjective, non-specific, aches and pains of daily living, so therefore we can ignore them. So and that's irresponsible. It's negligent. When you think of it, yes, I went to medical school, but what I'm talking about now, I didn't learn in medical school.
Yeah,
I learned from my patients.
Yeah,
and your doctor there should have learned from his patient, which he failed to do. And medicine is constant education, and we learn from our patients. If something doesn't make sense, then we have to change our theory and not hold on to a theory that's invalid and doesn't apply. So he failed to do that, and he couldn't think outside the box. And you can see that some people, they're black and white thinkers, where a lot of medicine, you have to weigh shades of gray. And when you're dealing with a complex, evolving, poorly understood disease, you have to think outside the box. You have to weigh contributors and explain something that wasn't explained before. And he was it laziness or was it rigidity? And
I think for me, my experience, because I saw a dozen doctors before I got to Dr. Phillips, I found it was just incredible dogma and rigidity. It was a knee-jerk. No, it was a knee-jerk response, and there was often a smirk accompanied.
I've seen a smirk in depositions.
As a patient, innocently sitting there saying, "Well, I've heard that Lyme could make you sick for longer than 21 days. That people are on doxycycline doesn't always work." You see a smirk, and I was actually told in the urgent care, "Don't Google Lyme." When I first went to urgent care, I went because I had the bullseye. It was a Saturday. I was told not to Google Lyme because they don't want me to be biased and swayed by all the crazy Lyme people. And I never even heard of a crazy Lyme person. What kind of a thing is that to even say?
Well, the Osler quote of the greater the ignorance, the greater the dogmatism. And it's you have to move forward in medicine, and you have innovators and laggards. He was a laggard. and he was someone who wasn't moving forward. And now I think you have some that propagate false information for whatever their reason is.
That's right.
And then I think you have these other rank and file doctors in the community who kind of take that at face value and don't really do their own research
Yeah.
and assume that that's the way it is. I think there's those two groups.
Yeah.
And, you probably were dealing with someone who read that. I've had a patient, and like he went to 57 different doctors.
Yeah.
And I was doctor 58 after.
Terrible.
And you don't usually see it, people going to as many doctors now as used to be the case.
Right.
People get it now more, but they still usually have to go to several.
Yeah.
And I think it's the people that are closer to the doctors, sometimes psychiatrists, family doctors, nurse practitioners, whereas I think some of the more rigid medical super specialists sometimes have an arrogance that, how can you tell me something I don't already know?
Yeah.
And there's, you can tell when someone, when you're hit with something that doesn't make sense, do you stop and think and try to explain it? Or do you just get rigid and dig your heels in and discount it?
There's a great story that we were told for the book by another psychiatrist named Dr. Preston Wiles. I don't know if you know him. He worked at Yale for a really long time. He's a child psychiatrist. And he told us that all the doctors at Yale used to have, the pediatricians used to have kids with psych problems and send them to Preston, to Dr. Wiles. And he would end up sending them, or they would end up going, a lot of them, to Dr. Jones, who was, may he rest in peace, a wonderful, wonderful pediatric Lyme doctor in New York. And they used to go to Dr. Jones, and he used to get them better. But it was so taboo for the parents to be taking their kids to a doctor who treated chronic Lyme, even though the kids were getting better, that the parents would swear him to secrecy. And he would get all the credit constantly for like curing these intractable cases of kids with psych illnesses, but it was all Dr. Jones by his own, admission, or by his own telling of it. So I just thought that was a remarkable story. And this went on for years and years and years, and they never knew that it was Dr. Jones. That just
when you have that arrogance and failure in a system,
yeah,
then it forces other people to treat the patients that are rejected by that belief system.
Yeah.
And when that belief system gets corrected, which I hope it would, then these people could, more physicians could fulfill their responsibility and treat these people more effectively.
Yeah. How can patients advocate for themselves? So right now, I'm hearing so much from the long COVID community, and we should, before we go, talk a little bit about the interplay between Lyme and COVID, because I know that there is one, and I've seen that you've written about it, and I want to talk to you about your experience there. But how can patients advocate with their doctors when they're being told it's all in their head? I'm talking about throughout medicine. I'm hearing it constantly. It feels like chronic Lyme on steroids, the stories that I'm hearing. How do you suggest patients approach this with their doctors and try to educate them and elicit a more open-minded response?
Well, it can be all in your head, because read the chapter I did on gliosis, and but there's a pathophysiology that is in your head causing it, but it's not all in your head imaginary.
Well, so that's what I'm saying. That's what I'm saying.
And psychiatrists we get it three ways. One, someone says it's all in the head, it's imaginary, it's functional, those kind of lines. The second is there are physiology to it causing the symptoms. And the third is the stress of dealing with the healthcare system, where they feel rejected by, and traumatized by.
That's right.
Okay, so those are the three things that we run into a lot. And I think, one article I did, psychosomatic, somatopsychic, multisystem illness, and medical uncertainty. In that article with Dr. Friedman, we addressed that. And also females are more likely to get a misdiagnosis of all in your head.
I know that. And why is that? Why is that, do you think?
the same complaint by a male would be taken more seriously.
Yeah.
And then someone said, well, I should have brought my husband when I had the exam, so they would take it more serious. It almost goes back to the idea of hysteria.
Yeah.
Females are hysterical, and there's that discounting of the symptom instead of thinking about it and trying to understand it when it's outside that person's, maybe it's above their pay grade, outside their ability to understand. Be nice if they could just be, humble with. There's the new movie out showing the girl that was blessed by the Pope. And
Julia Berzese. They did a wonderful job on that movie.
And when she was being assessed, the doctor said, well, let's lift her up and drop her on the concrete floor, and it will show that it's hysterical paralysis. So they dropped her and she fell on the concrete floor. And that
was
shows
a horrific story.
That shows the severity of this mindset, of this rigidity. When something doesn't fit with your belief system, how do you deal with it? Or do you have an open mind? Do you try to understand it? Or do you just force your belief system on someone? And I think you have to pick your battles. And I think when you advocate for yourself, what's going to be effective? And I think there's just some people that are closed-minded, and maybe you're wasting your time trying to advocate with those people.
Do you tell them, do you say to them, like, look, I don't think you're hearing me. I know this is hard. I know this is difficult when you're thinking it's one thing and I'm telling you it's the other. Like, does that work? What's effective in terms of communication? Because some people tell me, look, I'm in a town where there are 3 doctors in a rural town. I can't just go. I'm not in, Los Angeles or New Jersey or New York City where there's 1 billion doctors and I can just move on. How do we get doctors to listen?
Well, I think one reason is, why do they not listen?
Yeah.
And it's different reasons for different people.
Yeah.
And I think then the other is, well, if it's not that, what makes more sense? Okay.
That's great.
That's great. And how can you explain it, and how can you treat it? What's an alternative that's more effective than that? All right.
Yes.
And because you often see that where it's anything but Lyme diagnosis.
Exactly.
And say, okay, then what is it if it's not? And they don't have an answer. Okay?
Yeah.
So that it's hard to believe what it's, like I said, what it's not, unless they can say what it is. That's more plausible.
Right. So any sudden onset, I always use myself as an example because I was so extreme, I got a tick bite, and within a week or 2, I had severe sudden anxiety, depression, and insomnia, all 3 together. I also developed new OCD, which I never had OCD. In fact, I never really quite understood how OCD worked. I mean, never, you just want to say, stop, I know people in my life that I love, and I'm like, can you just stop doing that? No, they can't. Well, now I completely understand. And I also was seeing, I know you and I have talked about this because you presented about this, melting monstrous faces like the Scream every time I closed my eyes and I tried to go to bed. To me, that was, and I was being told it was stress. I was being told it was not Lyme, whatever it was. So, but not given any reasonable explanation. Is it fair for patients that have a sudden onset of psychiatric symptoms to go to their doctors and say, you have to evaluate me for infections? Is it common? Like, it happened to me, I hear it a lot, but is it common in your world that it really is an infection triggering this?
Well, if you have to force someone, they'll probably do a sloppy job.
Yeah.
And it's you can just see that you're wasting your time with that person.
Yeah.
And like in that case, and Dr. Founda has studied a lot of times the CNS, it can penetrate in the CNS very soon after infection sometimes.
Yeah.
And if you're bit in the neck, particularly when it's closer, you see more CNS symptoms.
I was bitten right here. Yeah, right on my shoulder.
And now some people, they have that rapid development. And I think the OCD probably is more of an autoimmune piece rather than inflammatory.
Interesting.
And so it's, and it may have to do with what co-infections you had. And some people take that pattern where you see those symptoms right away. And other
Yeah.
people take the pattern where it's slow and then they may go years and maybe there's a head injury or a stress and then boom, or an auto accident, they show the manifestation then, where
Yeah.
their body is no longer keeping it in check, similar to the herpes fever blister or shingles analogy. And so there's a lot of different patterns. And, I think asking, again, if what could make sense here, and it's, but your problem, these, how much knowledge do they have about psychiatry? So in some ways, probably family doctors maybe do a better job because they have that broader knowledge.
Interesting.
They have more psychiatric capability. I was dealing with an infectious disease doctor recently, and he said, well, psychiatric illness has no physiological basis, right? Neurological illness does, but psychiatric illness doesn't.
Uh-huh.
And it's like, where did that come from? It came from what he learned. And, and there was one deposition of a Lyme expert who's a rheumatologist. And they said, what was your training in psychiatry? He said, well, I had a 1-month rotation in a state hospital.
Wow.
45 years ago.
Yeah.
And that's where it came from.
Yeah.
And well, what ongoing continuing medical education psychiatry have you had since? Zero. Okay.
It's unbelievable.
So that's there's a knowledge gap about how to connect the dots.
Yeah.
There's the also saying to know syphilis is to know medicine.
Yeah.
Yeah, but to know Lyme, you have to know more than medicine. You have to know psychiatry. You have to know psychoimmunology. You have to know epidemiology. You have to know infectious disease.
Yeah.
You have to know many different fields and part of it's economics and politics.
Yeah.
So you have to pull together many fields, and you can't only look at it with the silo mentality and stay in the one field that you master. You have to venture out and learn the related fields so you can connect the dots. And that's a big part of the problem. These doctors can't step outside their training and expand with a disease that needs a broader knowledge base in order to really get a grasp on it.
It's astounding that you can, I will hear about the same doctor over and over that will see patients with Lyme symptoms that will never see the pattern. There is famously, there's one in New York City, and I hear, and every time he's an ID doc, and every time I hear from somebody from New York who's really mad, who just got their diagnosis after their 20th doctor, he was the one who told them they didn't have it. Okay. And he actually treated a friend of mine, and I looked through her records with her because she was actually going to sue him. And she ended up needing a hip replacement because her Lyme got so severe. He could have actually prevented it years and years prior. And she had multiple positive Lyme tests. He never told her. And in her record, it said false positive, check again in 3 months. And I mean, sometimes I just have no words.
Well, it's interesting how people just get locked in a belief system. And once they've done it in their one way, look at money, ego, power, once you're locked in,
yeah,
it's hard to say, whoops, I think I was wrong and I have to think differently.
Yeah.
And now some of us, and that's the difference of humility versus arrogance in medicine.
Yeah.
Some of us can do that and recognize that we really missed the boat on something and we need to look at it differently.
Yeah.
And if I look at how I conceptualize mental illness in my residency training, we had the concept of the schizophrenic mother. And there the theory was that the way the mother interacted with the child was what caused schizophrenia.
Ah, interesting.
It's like, oh my God, what a horrible theory that was.
Yeah.
And telling people that, but when in reality was the opposite. What happened was that these, these children were impaired and the mother hoovered because they knew they had to.
Absolutely.
It wasn't the other way around.
Before we go, I want to talk to you about COVID and Lyme and
right.
the overlap.
All right. Now, I think on one hand, the mistakes you see with Lyme, you see with COVID.
Yeah.
COVID does get more money and recognition, but you see that the same who do you turn to for experts? The frontline physicians who treat it every day,
That's right.
or the bureaucrats that never treat a single case and they just analyze data?
Well, we're not allowed to talk about cheap repurposed drugs. We never were. We can only talk, we'll let people die for a really long time until there's a vaccine and a new patented drug. I mean, that's kind of what happened with Lyme too.
Right. We saw the same thing, that public health, like prevention and vaccines, and don't use treatments, particularly if they're not FDA approved treatments.
Yeah.
And then you get the special interest with the finances that are involved. And you have people, in order to be effective, and to look at the people who were effective in the early part, they were people that could think out of the box and adapt quickly by their clinical observations. And these were the thought leaders.
Yeah.
But then they were a threat to people where it was a threat to certain economic interests. So then they attacked them. Similar with Lyme disease. Now, I think some people had both Lyme and, like, people that had Lyme and then got COVID. A lot of your Lyme treatments could be protected from COVID.
Yeah.
So people that were under active treatment with Lyme often did reasonably well. Some people that got who had Lyme and weren't under treatment and got COVID, it caused the relapse, and you saw a reemergence of their symptoms.
Yeah.
They might get Bell's palsy, they get long duration panic attacks. They had symptoms that were part of their Lyme that had been in remission after they got COVID.
Yeah.
And then I saw a couple of people, and this I wasn't sure of, but there were a couple of people, and this was more in the early part of the epidemic, where some people with the very high fevers. And some of the people with the high fever, that high fever seemed like it may have helped the Lyme.
Interesting.
May have been therapeutic. And think of the hyperthermia treatment that's used. And I've seen that with some people. Let's say they have an infected port, and then they have a high fever, and then their Lyme may improve afterwards, or certain Lyme symptoms would improve. So those were the patterns that I saw. And like, I've seen people, like in the household, the whole household gets it, and the person with Lyme is under treatment, does better.
Yeah, I've seen that.
And there's a number of treatments that seem to work. And
but given how asymptomatic Lyme can be and how asymptomatic COVID could be, these are two weird diseases that can be just lie there dormant and latent for a while. Is it also happening that COVID is triggering latent asymptomatic Lyme or Bartonella or other diseases, and the patient is completely, because what I think I'm seeing is a lot of people who never were familiar with vector-borne diseases get long COVID, and then they get all these symptoms that look like Lyme. And I've seen a few of them go and investigate, find out it was Lyme underneath too, and treat it and feel a lot better from their whole.
Yeah, I think there's other things that get activated, not necessarily Lyme or tick-borne disease, vector-borne disease. There may be other infections that get activated if you have it. Now, it seems like what's going around now with the COVID isn't as bad as what was there before. So the whole thing of the naming of it, it's just like this bogus term, post-treatment Lyme.
Yeah.
It's like, was it adequate treatment, inadequate treatment? Was it in time? Was it delayed? That's a bogus name. And long COVID, that's not a medical term. It's chronic. It's now it's chronic symptoms. We could argue whether it's chronic infection and chronic symptoms, or whether it's just chronic symptoms without chronic infection, although we don't know if there's still persistent infection or persistent infection of what. And but it's a chronic illness. And label it properly. Yeah,
absolutely. These semantics inform treatment, and that has absolutely been the case with Lyme. I vehemently object to the term post-treatment Lyme disease syndrome. It is chronic Lyme, it is persistent Lyme. I'm not, I can't say it. I can't say post-treatment Lyme. That's totally where I got off the rails, where my treatment early on, that's completely what I was told. And I took it really literally at face value. And I kept going back to the CDC website, and they said in a few months, people with post-treatment Lyme disease syndrome, they usually get better. Well, how about the ones that got worse, like me and millions of others?
Well, I've seen thousands of Lyme patients. I wouldn't be seeing these patients if these treatments worked.
Of course.
It's and if that false information weren't out there, I wouldn't see so much of it.
Yeah. Yeah.
And then I could do easier things to work with. Instead of dealing with these very complicated Lyme cases that somebody screwed up with it.
Yeah. Yeah. No, I understand. Well, I know that your practice is, you're not taking new patients, but you will be able to send me a list of some practitioners that know a lot about the psychiatric manifestations of different infections that
Yes.
maybe I could share with some people. And are there good places that you could point us to where doctors or patients can learn from you and people like you?
Well, I do a list for doctors to learn. I've been doing that for 20 some years, called Microbes of Mental Illness. And there's, several hundred from 20 different countries.
How do people subscribe and how do people find?
Well, that would not be a general, that would be for doctors.
Okay.
Or clinic, like psychologists, social workers who work with these patients.
Okay.
But then there's also educational programs for psychiatrists that we do. We do a monthly program for psychiatrists that want to learn more, and nurse practitioners and clinicians in general. And then there's also different programs. For instance, the ILADS program. We're going to do that, repeat that in Hershey and Marsh.
Okay, so there's stuff out there, and you're continuing to rock and roll out there teaching people. I know that, and I thank you so much for your time.
Okay, it's a pleasure.
Is there anything I missed that you wanted to say, or do we cover all the ground in this last hour and a half?
Well, you have to keep an open mind and deal with people that have an open mind, because, picture like when I look at where I was 50 years ago with medicine and now, and where's medicine going to be 50 years from now? Or 10 years from now, 20 years? And what are people in the future going to say about the Lyme crisis now? Are they going to look at it like the Tuskegee experiment?
Yeah.
And say, that was disgusting that those people were just saying, well, there wasn't enough evidence, let's do more research.
Yeah.
Right? And I'm sure that I think this will be judged by history as a great failure of our healthcare system, that we didn't move quickly enough with this, and that people were holding back forward progress.
Yeah.
And it's, it's, as time goes on, we're better explaining things that we couldn't explain before, but things that before we knew from clinical observation.
Yeah.
Now we have more and more of the physiology that explains it, but because people are locked in, there's an old quote that science advances one funeral at a time.
Yeah.
Okay. And I think you have people that are just so locked in and have given misinformation for so long, and their reputations are dependent on it.
Yeah.
They're not going to say, whoops, I made a mistake, I was wrong.
Yeah.
And Dr. Jones was right, I was wrong.
Right.
No, they won't say that, but those people will eventually retire, and people that aren't as invested in misinformation, I think, then would come along, and I think there would be people that would be more open. But it's a struggle. This is the same struggle with any new idea, be it in medicine or anywhere else, to take hold, is that people get invested in old beliefs that don't work anymore. That's right. For reasons other than just the accuracy of information. There's 400 and some articles showing an association between these tick-borne infections and psychiatric illness. There's overwhelming data. And for someone to say that it doesn't cause it is, that's without any scientific, and those are peer-reviewed articles.
Yeah.
And a large number with the dementia too, but 80 some for that. So it's
for decades. I mean, it goes back decades.
Right. It's overwhelming.
Yeah.
But yet but someone who has a belief system, they can't get outside that belief system. So keep doing what you're doing. It's good that you educate, you educate, legislate, advocate, sometimes litigate when it's necessary. Yeah. That's how you affect the change.
Absolutely.
You have to do all those things, right?
Absolutely. And getting people like you out there to tell it like it is, to set the record straight. So I'm so appreciative
Okay.
of you, Bob. It was great to see you.
Okay, Dana.
I'll see you when I get back east. Thank you for joining us for this episode of Ticktective, a program of the Bay Area Lyme Foundation. For more information or to get involved, please visit us at bayarealyme.org.